Hi guys, so these are nursing skills and knowledge that I developed in the nursing home that has been a blessing to me in the hospital. So it's not been all bad. Let me be honest with you guys. So these are a few care home skills that have been a blessing to me in the hospital, in the ED, if I should say. If you're interested, stay tuned. Stop that. So hi guys, welcome once again to my channel. So recently, as I've said in many of my videos, I left the nursing home after 5 years and 6 months to the emergency department. Very chaotic department. Right. And I've done videos where I shared my embarrassing moments during my induction period, a lot of things that I did not know earlier, a lot of things that I was not familiar with because I was coming from a nursing home, which is a totally different environment. However, that I must be honest that certain skills and knowledge that I developed in the care home that has been a blessing to me, even in the ED. So first of all, let me talk about documentation. So in a nursing home, there's a lot of documentation. After every shift, you are writing documentation depending on the unit you are. For example, where I was working, there was a unit that had about 24 patients, okay, or 24 residents. And as a nurse, at the end of every shift, you're being tasked with writing documentation or progress notes for all of these 24 people every single day you go to work. And this is not just any documentation at all. I don't know about other nursing homes, but for the company that I'm working with, in your documentation, you're supposed to talk about the person's medication for the day. You're supposed to talk about the person's mobility for the day. You're supposed to talk about the person's diet and nutrition during the day. You're supposed to talk about their personal hygiene and elimination. You're supposed to talk about their skin if there's any concerns, and even sometimes their spiritual well-being, their cognitive well-being, and all of that. So we do thorough documentation in the nursing home at the end of every shift. So when it comes to documentation, I mean, I've been doing this for so long and I know very well that the documentation your patient's notes can be used in court. I know very well it can be a legal document as well. So over the years, I developed the skill of learning what to write, and I developed the knowledge of knowing what to write in order to cover my back. For instance, if let's say you complain that a patient has not moved the bowels in, let's say, 5 days, knowing that, I will not just state that, right? As a nurse, I would have to state that, knowing that it can be used against me in the future, and then also state what my nursing interventions were. Did I encourage fluid? Did I sit the person on the commode to try and see if the person will move? Did I try to move the person in bed? Did I administer any PRN laxatives if the person is not on any PRN laxatives? Did I call the person's GP to request for PRN laxatives? If the GP did not respond, did I call out of hours? If I called out of hours and they prescribed it, have I gone for the medication? Has Boots delivered the medication? Did I administer the medication? Did the person take the medication? What is the feedback? Has the person pooed? Have you handed over? So because you've been doing this for so long, you know that what you are writing can be used against you. So you're making sure that you are covering your back and you are doing the right thing as you go by to save yourself. So when it comes to documentation, I mean, we do it so much in a nursing home that it hasn't been a problem. The only difference with the documentation in the ED and the documentation in the nursing home is, like I said, the hospital I'm working with is very high tech, high class. So we are always typing. And in the care home, my care home, we were still writing pen and paper. So it's very different because I'm not a good typist. So that has been the problem. But also in the ED, I don't have to write notes for 24 people. You understand? So documentation is a big deal. I developed that skill in how to document. For instance, if somebody is admitted into the care home and the person came with a gold necklace, before I would write a gold necklace, but through working in a nursing home, I was corrected at a point in time to say that, have you checked whether it is real gold? So just say yellow colored metal, to save yourself. What if the person is being discharged and is asking for gold and you give them their necklace and they say, no, this is not the one because it's not gold? You understand? So a lot of ways to protect yourself legally, and I have developed that skill massively in a nursing home, and I am applying that in the ED as well. So that has been a blessing. So documentation, number one. I wrote all of these down. So number two, I would say swallowing, choking, thickening, right? So in the nursing home, we care for lots of people that have swallowing difficulties, people that cannot swallow, people that are at high risk of choking or of aspirating. So when it comes to managing people with swallowing difficulties, somebody who's just had a stroke, somebody who is not able to control the head, or people in general that have swallowing difficulties, I know how to manage them so well. I know the different kind of thickness. I know the different kinds of meals. If the speech and language therapist, let's say, says this person is on level 5, I know immediately without looking on any chart that level 5 is minced and moist. I know what I can serve my patients. I know what I cannot serve my patients. Other than that, they're going to choke. I know all of these to detail. And then I also know, some safety things that I have to do. I have to keep the person upright in bed. I have to make sure they are alert before I put anything in their mouth. I have to make sure that even those that have severe swallowing difficulties, if I'm giving them their medication, I can give it to them with, let's say, yogurt instead of, let's say, water. Or I have to thicken the fluid that they are taking the medication with. Or even better still, I have to request for syrups instead of tablets if possible, just so that my patient is safe and they do not choke on the tablet or anything at all. So one of the days that I was working, and I was so proud of myself. I mean, this happened. I got a patient who had not eaten the entire time. When they handed over to me, they told me this patient had not eaten, refusing meals, blah, blah, blah. When I was giving the person the tablet, I realized that this person cannot tolerate the level that they said he's on. So I was really concerned. So the first thing I asked the family when they came was, what kind of meals does he eat at home? And they described level 5. But meanwhile, let's say they told us, let's say he's level 6, but he was not able to tolerate the level 6 meals. He was not eating it. It was just in his mouth. He was unable to swallow. So that was a very high risk. But because I knew that there's probably something, he's probably not on this level. He's probably on level 5, right? I phoned the kitchen. Look at me. I requested for level 5 and they delivered level 5. My patient ate the entire bowl. Immediately began to look better. The guy was hungry. You understand? So this was a skill. I know how to deal with people with swallowing difficulties. Even in the nursing home, sometimes if somebody is referred to the speech and language therapist and they have not had time to come, we are able to tell that no, this person has been choking on their thin liquid or on their water or on their juice these days. So why don't we take into level 1 instead? And I know that, I know how to mix with a thickener. I know all of that. I mean, that is easy. That skill, it helped me as well. The third one is how to manage conditions like dementia, diabetes, Parkinson's, learning disability, falls. So in the nursing home, I mean, there's some things that are very, very, very common. We have lots of dementia patients. We have lots of falls in the nursing home. We have lots of people with Parkinson's. We have people with diabetes. So we manage these things very well. So if somebody is on lots of medications because of the person's dementia, I know all the dementia medications you can think of and I know what each one does. I mean, because I have given them for 5 years. Why won't I know them? I know them. Unless the company that produces them changes the color of the packaging. I know the color of the packaging. You understand? I know that in this particular medication, it usually comes in 5 milligram and it also comes in 10 milligram. I know that so well because I have given them 5 for 5 years. Parkinson's, those that have Parkinson's and are prescribed Madopa. I know that with Madopa, usually the times of administration is very critical and it's critical medication. And I know that sometimes it is administered at very odd hours because of the way it is. I know that already. So if I have a patient and the system says this person has Parkinson's and is on Madopa, I know that I have to check because with that medication, the time of administration is critical. I have that knowledge already. I've dealt with so many people with Parkinson's. And for instance, somebody with diabetes, we manage lots of people with type 1 diabetes, type 2 diabetes. So I am very familiar with the medications. I'm very familiar with the types of insulin that can be prescribed, how to administer the insulin and all of that. People with learning disability as well. I've had residents in a nursing home who have learning disability, how to talk to them. I know how to approach learning disability patients with medication. I mean, there's this learning disability patient I had in the nursing home. If I want her to take her medication without any issues, I start singing from the entrance. Let's say she's called Nanelle. Hi, Nanelle! How are you today? I missed you. And before I get there, she's opened her mouth. But if I forget myself and I get there, hi, Nanelle, can you open your mouth and take your tablet? She's not going to. She likes to be pampered and spoiled. She likes you to come in a happy mood. I know how to deal with that. I understand. You understand? So it's easy for me when I see people in the ED struggling with people with dementia and not knowing what to do. I have dealt with so many of them and I'm used to it. By the way, this video is proudly sponsored by Lemfi. So for those of you who are hearing Lemfi for the first time, Lemfi is an international money transfer company that allows you to send money from the UK, from Canada and the US to over 10 different African countries. You can send money to Ghana, to Nigeria, to Cameroon, Senegal, Ivory Coast, Benin, Tanzania, Rwanda, Kenya, Uganda at zero transfer charges, zero fees, nothing at all. And on top of that, they have the best rate on the market. Compare Lemfi's rate to any other app, they are always the best. And so I recommend Lemfi. If you're in the UK, you're in Canada or the US, and you want to transfer money to friends and family in any of these countries that I have mentioned, okay? As well, if you use the code NANEL, you get £15 cashback on your first transfer above £100, okay? And then you can also always generate your own referral link and then send to friends and family. So when they use your link, you get a bonus as well from Lemfi. Lemfi is the best, and ever since I discovered them, that's what my friends and my family have been using. Thank you, Lemfi, for sponsoring today's video. Falls. People who come with falls, I know how to deal with them. I know the protocol for, falls. If the person is on a blood thinner, I know that is important. I know I have to do neurological observations. I know on the things to do. So with management of falls and all of that, we deal with a lot of falls. Sometimes when there's a fall and then we call the person's GP or out of hours, they tell us what to do. And instead of sending the person to the hospital, they tell us what to do. So for those ones, I do have an idea on how it is managed. The chronic medications, like people with cardiac issues and all of that, their medication, I'm so familiar with all of them. So they were not new to me. You understand? So chronic medications as well will be like the fourth thing. And then number 5 will be blood sample collection. So in the nursing home, sometimes we have people on medications that require them to have regular blood investigations. Like people on clozapine, they are required that their bloods are checked, I think every month before they are given their next dose. Somebody like people on warfarin as well, their INR is checked quite regularly. And then, in general, some of the residents are old and then they begin to deteriorate. Their GP is going to ask for blood sample to do some investigations to see how they are faring and all of that. And then in my nursing home, I don't know about other nursing, but in my nursing home, that job was a job of night nurses. And as you know, I was a night nurse for so many years. So I was the one, usually if I'm on duty, to take the blood. So although I was not inserting cannula, I was doing a lot of venipuncture. I was entering lots of veins to take blood sample. So that was quite helpful as well. So I knew how to use the butterfly needle. I remember I went to work in another nursing home and there was this Nigerian lady who was usually doing day shifts. And in that nursing home as well, it's just the night staff that take the blood. So when I did my night shifts, I always used to take the blood early in the morning before the day staff come. But this time around, this day staff nurse, she came very early. So she came just when I was going to take the blood. And she said, "Nanel, have you taken the blood already?" I said, "No, I'm yet to." She said, "Can I take it?" And I said, "Why?" She said she hasn't used a butterfly needle and she's from Nigeria. We came around the same time. She hasn't used that kind of butterfly needle before. And because she only does day shifts, she wonders how it's going to be when she starts doing night shifts. That's how much she wanted to try to take the blood. But because I was doing nights, I was quite familiar with that. Number 6, personal care and elimination. So in a nursing home, nurses are also required to assist in personal care. We bath the residents, we give them bed bath. If they want to shower, we give them showers. And then we also help with their toilets and needs as well. There are some people that cannot mobilize, so they're not able to go to the toilet, so we have to change their parts in the bed. I do all of that. How to reposition patients with a slide sheet, we do that in a nursing home, so it's not a big deal for me. Personal care is not a big deal. It's not nasty for me. So even when we don't have enough band 3 staff to help us with that, I'm good. Like, I know how to wipe it clean and beautiful. In fact, if you give me the chance, I'll put powder, make you smell so nice, make you so comfortable. You'll be so happy. You'll be so happy. That is my specialty. Communication with patients, I think that's a skill as well. Like I said, that's a skill. I know how to, comfort a patient. Don't worry, it's okay. You're right. You'll be all right. Give it just about 30 minutes. It's going to kick in very soon. But just let me know if you're still in pain. Is that okay? Hi, you're right. I know that. How to communicate with patients, families. I know that. I know. In the care home, everything is called next of kin. Everything. From when I first stepped foot in Northern Ireland, when I could not hear them, till now, I know how to talk with family members. I know how to talk to calm their heart. I'm not saying giving them false hope, but to calm them down, to reassure them that we are doing the best we can, to make them so comfortable, to make them trust me and trust me with their grandmother and trust me with their grandfather. You come with anger, you be ashamed. I'll treat you the best way you even feel sorry. Therefore, coming to me in anger is a skill, and I learnt it in the nursing home. Handover tips. So in a nursing home, we always hand over. From the day staff to the night staff and vice versa. And also we do hand over a lot to paramedics. We do hand over a lot to GPs and GP out of hours. So let's say you are handed over a patient who's critically ill, and let's say in the night they begin to deteriorate. Let's say very, very bad. They are not responding and all of that. We do have a special hospital transfer form in my nursing nursing home that has all the important details that you need when you're handing over a patient to, let's say, the paramedics, or to, let's say, the ward or the hospital or whatever. And I have done this so many times that I know the things to say. I mean, aside SBAR, which is very popular, or SBAD, as some people will say, situation, background, assessment, recommendation, blah, blah, blah. I go beyond that. I know also the things to say. Does the person have a DNA CPR or DNA R form, or is the person for full resuscitation? I know that that is extremely important, and I have to hand over that. I know how to also communicate other vital things about the patient to make you know in 5 minutes everything you need to know about the patient when I'm handing over. So my very first handover, I think I did impress the person that was on the other line, and that was my very first time. And me knowing myself that I'm going to do a good job, I mean, I still went ahead to say, sorry if I don't do it well, because it's just my first time, so please forgive me if I don't do it well. I knew how to do it, but so I just went ahead, blah, 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 blah. Name, age, DNA R or DNA R not present. I went through the person's file on Epic or Encompass, and then I was also wise enough to know. So in the hospital, it's slightly different because you also have to let them know the plan of the doctor and then what has been done and what has not been done. And I had already, my preceptor for that particular day had showed me where to find all those details. And me also knowing very well that they are admitting this patient to the ward. And like I said, in the nursing home, we have like a template for documentation. 1, 2, 3, 4, 5, 6, 7, 8, 9. So 1 is, does the person have mental capacity? Does the person have dementia or whatever? Does the person's so 1. And then 2 is the person on any critical medication? So if the person is on, let's say, warfarin, the person is on, let's say, apixaban, or any critical Madopa, any critical medication that is worth mentioning, you mention them. Insulin, you mention them. 3 is the person's mobility. Is the person requiring assistance of 1, assistance of 2, assistance of 3? Does the person need a rollator? You let them know. 4, what kind of diet is the person on? Is the person nil by mouth? Is the person on, let's say, soft diet? Is the person on thickened fluids? Is the person on a PEG tube? You do that. Number 6, skin integrity. Does the person have any wounds? Does the person have any dressing? Does the person have pressure ulcers? If it's pressure ulcer, what stage is it? If it's a dressing, what kind of wound is it? You understand? And I think number 8 will be cognitive, their well-being, their spiritual welfare, and all of that and all of that. So if I'm going through the template that we have in a care home, in 10 minutes or less, I'll give you everything you need to know about the patient without you even asking me. And I'm going to include SBAR as well. So it will be a perfect handover. You'll be shocked that I've told you everything you need to know. You understand? And a few things about, let's say, the plan of the doctor, what we have done and what we have not done, and that's it. And that I learned from the care home. Big ups to care home. It's not all that bad. So the next thing I'll say is pressure ulcer grading and prevention. So in the nursing home, lots of people we cater for are unable to mobilize on their own. So they are at high risk of pressure ulcers. They are immobile, they are being nursed in bed, they have poor intake of food and all of that. They are incontinent and all of that. So all those things increase their risk of getting pressure sores. And then in the nursing home, it's a big deal if somebody gets a pressure sore. It's like you are not taking care of the person well. So it's a huge deal. You're going to do a DATEX if it's grade 2. So I know how to manage pressure ulcers very well, and I know how to grade them. So if I see somebody coming to the ED and we are providing personal care, I see that the person's bum is red, I know how to check whether it's blanching or non-blanching, and I know how to grade it to say, oh, this is grade 1, this is grade 2, this is grade 3. You understand? So that also really helped me. I know the kind of repositioning techniques to do to release your pressure off certain parts of the body, like parts that are prone to pressure ulcers, like the heel, the back, the bum, and all of that. How to provide zero pressure in those areas so that you can reduce the risk of pressure ulcers and all of that. So that was also very helpful, and I learned this from the care home. And let me also say policies in general, and legal stuff in general relating to nursing that I'm sure anybody who has written CBT knows about these things. These things as well, I learned them from, like, how to be careful in general, how to protect your back, I learned them all from the nursing home. So let me know if you left the nursing home to the NHS. Let me know some skills that you developed from the nursing home that you were able to transfer into the care home. And let me know if you have any of such and if I left anything out. The care home is not all that bad. It's not bad. It's not bad like that. Thank you so much for watching. Bye.